Benecia.
All right, so today we've got a very exciting talk about the different interventional fellowships you can do after doing your PM&R residency. So there's usually three main routes. One is ACGME Sports Medicine. So that's Dr. Benecia Williams. So she did hers at JPS John Peter Smith in Fort Worth, Texas. And then there's ACGME Pain Fellowship, which is Dr. Justin Thompson. He's our guest today. And he did his at Virginia Commonwealth University, so VCU in Richmond, Virginia. So welcome, Dr. Thompson. And then I did my fellowship, and it's a non-ACGME Sports and Spine Fellowship at Desert Spine and Sports Physicians in Phoenix, Arizona. So today we'll kind of talk about each kind of fellowship and why we chose the fellowship that we did. Hopefully Tristan Zhang, Dr. Zhang, he can join us. He did his pain medicine fellowship at University of Nebraska in Omaha. So to get started, I'll have Justin we can all go around and just talk about why we chose the route we did. And Justin, if you want to go ahead and start, we'll go from there.
Sure. Thank you guys so much for having me on the show today. Happy to be here. Thanks to
Thank you for joining us.
Justin actually was our senior, so PGY 4 when we were medical students, I think. Yeah.
When we rotated, yeah.
Yep. We both rotated at Baylor and Dallas, and he was PGY 4 there. So.
That's right. That's right. Well, it's great to be here, and I'm happy to see you guys are doing great things in your own right. Made me proud. Seeing y'all do your things y'all are doing, especially this show. It's excellent. So.
Thanks.
So my name is Justin Thompson. I'm a pain management physician here in Dallas, Texas. I work with a group called Dallas Pain Consultants. Also do some addiction with a group called Foundation Medical Group. I got into pain because I thought it was a way to give people the quality of life that they wanted, which I thought was a natural segue to physiatry, which was my, residency. I thought that, by being able to offer interventions, we could limit the amount of opiates that we have to write, which is kind of my general approach as a pain doctor, more focused on interventional pain than, medication management, that we could give people the quality of life that they were looking for. So really, that's what drove me there. I actually got hurt when I was a third year medical student playing soccer. And, I didn't know what was going on at the time, but I had a cervical radiculopathy. And so, my primary care doctor told me that I could get a shot in my neck, which, at the age of 21, 22, kind of a scary thought. So, fast forward through my PM&R rotation, I kind of found out what that meant. I opted for the physical therapy route. Thank you for all the physical therapists out there. I appreciate that. You guys got me better. But, some people don't, and they need injections, and, that's what I'm here for. So that's how I got here.
All right, awesome. So Tristan is on. Yay, welcome, Tristan.
Hey, how are you guys?
I'm glad you're able to make it on. Yay.
Hey, yep. So so Dr. Zhang, so Tristan, what we were saying is we are just going around talking about why, we chose the fellowship that we did, why the route that we went to. So Justin, if you want to go in a little bit more detail about why did you choose a ACGME, pain fellowship under the PM&R umbrella? Because so Dr. Thompson did his pain medicine fellowship at VCU, and it's in the PM&R department. Dr. Zhang, he did his ACGME pain fellowship at University of Nebraska, and it was actually under the anesthesia department. So we can kind of go into the nuances of both of those. And so Justin, if you just want to say, like, why did you specifically choose an ACGME pain fellowship versus the other options out there?
So I wanted to keep my options open. I think that, when we were at Baylor, some of the attendings had voiced the need to, keep your options open. There were, some rumors that you couldn't get credentialed at certain facilities because you didn't have ACGME pain, versus some of the other options that were out there. That may be a wise tale at this point. I haven't really seen that bear itself out, thankfully. But, that was kind of what drove my decision making at the time. That being said, I know lots of people who are interventional spine or PM&R or other, interventional docs that are not necessarily pain management. So, if I had known what I'd known today, I may or may not have made that decision. Also had a lot of interest in neuromodulation. So I wanted to learn about pain pumps and stimulators. I like the idea of doing implants. So that was something that the fellowships, in pain in particular offered. And I wanted to be able to prescribe opiates in a way that was responsible, and that's kind of what also led me into addiction like I do now. So I feel like that's one of the reasons I wanted to do that. PM&R is one of the top specialties in terms of prescribing opiates. And so I wanted to have a responsible way to carry that forward. It's hard, sometimes when you're young, starting with these patients on big doses and saying, well, what's next once tolerance and physical dependency set in? So, that really drove my decision-making process.
Great. Okay. All right. What about you, Tristan? Why did you choose the ACGME pain medicine fellowship route?
Yeah, kind of like Justin, I wanted to mostly keep my options open in terms of getting credentialing. I looked at some non-ACGME accredited programs, and I thought they were really great as well, very well-rounded programs. So, I think either route that you take, you'll get really good training. For me, it just kind of fell upon me, coincidentally almost, that I was under the anesthesia department. I had also interviewed with programs with PM&R, but I thought it was very interesting coming from a PM&R background to work with people in a different department. So I also wanted to keep my options open in terms of the different procedures that we did. So University of Nebraska, we did a lot of diverse set of procedures, including pain pumps, neuromodulation, with stimulators, as well as a lot of kind of bread and butter interventional pain procedures. And it was actually one of the few programs that did kyphoplasties as well. So I thought it was a very well-rounded training experience for me.
Very good. Excellent. So I guess it's on me now, huh? So we all trained at Baylor, and we all had a chance to rotate with Dr. Andrew Conan, who is amazing. He's an anesthesiologist that's trained in pain management, and he kind of mentored all of us. And he loved having PM&R residents because we had brought the background of being able to do like the full exam and then translate into that to the diagnosis and then doing the appropriate injection. So I knew I wanted to be interventional by my third year of residency. So Sheena and I sat down and kind of discussed and talked about the different options. So I knew I did not want to go through ACGME route. I was not as interested in doing pain pumps per se. So I just may want to do more of the bread and butter injections, along with doing a lot of general PM&R, which is what I do, and we'll talk about that later. I wanted just more additional tool belts in my tools in my belt to help treat my patients. So I interviewed at both non-ACGME sports and spines programs, and I interviewed at ACGME sports programs that were doing interventional. They had to have the fluoroscopic aspect of it, as well as the ultrasound aspect of it. So that's what I went and did both of those. I was offered a spot at a ACGME, non-ACGME sports and spine place in Florida, but I had decided to stay here since I got into JPS, which is a wonderful family medicine based, I shouldn't say family medicine, it's a wonderful primary care sports medicine fellowship that does interventional. This particular fellowship a few years ago used to be a 2-year fellowship where you could do ACGME sports and ACGME pain medicine. So that's where they had the interventional aspect was still there. It just wasn't ACGME certified anymore. So yeah, that's why I ended up going to where I went.
And that's an important distinction, right, Benecia, because some of the ACGME sports medicine fellowships, they don't do spine. So you wanted to make sure that you could get that spine training. So how did you find out, like, how would you find out like which programs do that?
Yeah, so I know, so when you go to apply, if you do sports medicine, I think there's 18 PM&R based ACGME Sports Medicine fellowships, and some of them do it. But I want to say, I did a lot of Googling. Next week, we'll have my friend, Dr. Rachel Wilbell. She interviewed at almost all those programs, and she can probably elaborate more. But I think there's only like 5 ACGME sports medicine programs that are doing interventional spine. I think Stanford's one of them. Utah has a program, RAC in Chicago, JPS, and I feel like there's another one that's doing it as well.
And so, so like Benecia, Justin, Tristan, there are a lot of great options. The reason why I didn't apply to any ACGME fellowships. I didn't apply to the sports or the pain fellowships, just because I think it's important to know exactly what you want to do in your career. So I knew I didn't want to do, pain pumps, or I wasn't interested in cancer pain or some of the other required, aspects that you would do in a pain medicine fellowship, at ACGME Pain Medicine Fellowship, and ACGME Sports Medicine. I know I didn't want to do a lot of like sporting coverage, all that. So
it's a lot.
So I kind of picked what I thought was best for me, which was kind of a hybrid kind of fellowship where you do sports and spine. So I applied to just all, there's about 10 programs or so that I applied to, and I ended up at Desert Spine and Sports Physicians. So the stuff I loved about that program and the non-ACGME fellowships is that majority of them are in private practice. So I knew when I finished my fellowship, I wanted to come back to Texas and work in a private practice. And so to learn how a private practice is set up, so learn all about billing and coding. You got tons of hands-on experience. So the thing is, there's kind of a rumor out there, saying that you may not get accredited at different, hospitals if you won't go to a ACGME, if you don't go to an ACGME fellowship. So I fortunately have not had any issues. So I'm credentialed at 5 different hospitals here in DFW. So I haven't had any issues with that. But saying that, I do know just a very small handful of people who have had issues, at academic centers. So going this route, you do have to, know that could be, a hindrance when you are applying for jobs, but I think it's rare.
Yeah, especially in academics, more so probably in the academics versus the private practice world.
Exactly, yeah. So that's why I felt comfortable, going down this route. And I also knew I wanted to keep my skills up with EMGs. So EMGs is still a part of my practice, and I felt like maybe if I went to a pain medicine fellowship, you don't get that experience there. So I wanted to keep that skills up, because with EMGs, if you don't do it after a year, I think it's hard to get back into. I think Benecia can attest to that.
Yeah. You got for my fellowship. I remember getting an email from our program coordinator. She's like, "Hey, Benecia, do you want to do EMGs? If so, what day do you want to do it?" And I was like, "Wait a minute, I have a choice." I was like, "Negative, please, and thank you." I just knew it. I think EMG's like either it's for you or it's not for you. It was not for me. So right. Even though we had great training on it, it just if you don't keep it up, you will lose that skill.
Definitely. I think another thing with the non-ACGME fellowship, there are tons out there. You have to be very careful about which ones, right? So there's some that they may just use you just as an extra person, in their practice, kind of just to make money off of you, and the training or in the education opportunity is not very good. So that's why you have to do your research and kind of see which ones have that great, didactics program
right.
within that program. So well,
I want to say what's up to Dr. Zaman. He's on. He was our PGY4 when Sheena and I were PGY2, and he was a very big resource for Sheena and I. Yep. When we were applying for a fellowship, because he did a non-ACGME sports and spine fellowship and kind of really shed some light for us.
Yep, and he actually, he did his non-ACGME sports and spine fellowship in Mount Sinai in New York City. So there are non-ACGME fellowships in academic centers. So not, so if you do want to have that experience, you can still do one of those there. But we'll kind of move on, and we can kind of talk about applying to these fellowships. So Justin, Tristan, you guys did the ACGME pain. So kind of what advice would you give to residents who want to go that route, and like the match process and all that?
So, applying, it can be a lot because you want to cast a wide net. I think that's my first piece of advice. Pain is competitive. So, even if you've got great scores and, good history from med school with your steps and all that comes into consideration in great letters, there's no guarantees, for getting into the ACGME type programs, and all programs are competitive. So that's no different in the non-ACGME accredited programs are actually sometimes more competitive because of the fact that there's limited amount of slots there. So it's going to be tough. So regardless of which direction you go in, you definitely want to cast a wide net, regardless of where you are, just to give yourself options. Secondarily, it can sometimes be a repeat of applying for residency. You remember applying a bunch of places, trying to figure out which interviews you can go on, which ones you can't go on. So, prioritize the programs that you think you really want to go to. I was fortunate enough at VCU, we were at a time frame and where the match was just being phased in. So we had, programs in and out of the match. More programs have shifted now to being in the match, but there are still a few that are maybe outside of the match. And so, when you're there, I told, the program I went to VCU, and I feel fortunate to have gone there. I told them I wanted to be there, so that's a big part of it, so making friends with the residents and when you're a med student is always a good option in terms of getting into that residency because, we have kind of a say in terms of whether you get in or not. Same thing applies with fellowship. If you want to make friends with the people who are there, can be a little more difficult because it's a 1-year thing, but definitely trying to get to know the people who are there, and then also to just understand what's going on and if it's a good fit for you, is a good thing. So for me, I think, prioritizing, because you're going to have to pay to go on these interviews, and that's coming out of your pocket, which can be expensive. And then letting the people know that you really want to be there makes a big difference. And then if a program, does happen to offer you a spot, take it if you want it. That's definitely a big thing. Programs are sometimes not shy about, even within the context of the match, letting them, that they have interest, and, you definitely want to reciprocate that. Obviously the process got to play itself out, but, there's still some human elements there as well. So that's a big thing. Also, being kind to others. If you do decide to drop out of the process or you do get a spot, make sure that you drop out of the match because these spots are competitive and, you want to make them available to other people, in case you decide, and just keeps your name good. I've known some people even on the non-ACGME side who didn't drop out in time or, didn't vacate a spot, and that just doesn't make you look very good. So be considerate of others. We definitely need to look out for ourselves, but also other people too. So that's an important step.
And that's the timing, right?
Yeah.
So Tristan, if you want to go into detail, like when did you apply for, when in your PGY year do you apply, and kind of that match, figuring out the timing.
How many programs did you apply, the rank, and things like that?
Yeah, I would add on to what Justin said. Try to get your materials in as early as possible, especially with med schools, transcripts, that takes a bit of time, rec letters. So, establishing good relationships with your faculty and trying to get the rec letters, give them enough time to prepare and write the rec letters. So for ACGME pain, I remember the ERAS cycle opened up around December of PGY3 year. So you pretty much have about like a year and a half, to kind of figure out, if you really want to do pain, and also which programs you want to apply to. I applied pretty broadly across the board. It is a fairly competitive fellowship, so just to keep your options open. And so when the application cycle opened up, I pretty much applied around like late December, early January. And then the interviews start like early that following year. So around this January to May-ish, that's when you start getting the invites. And they interview, I think, all the way up until like early fall of your PGY4 year. And then the match happens in October of PGY4 year. So yeah, I would say, one of the biggest things that came up was geographic location. And, I think it is somewhat of an advantage if you stay in a certain location. you get that extra year to build up relationships with other coworkers in that area. But I was fortunate enough because I kind of knew I wanted to come out to the West Coast during that year. So I had two faculty that were also trained in California. So I was fortunate enough to establish some good relationships and network ties in California during that year. So I would just say, if you can apply broadly, and don't keep your options open.
Can we give a what's up to Dr. B, just signed up, Dr. Bayazatilu, who also mentored all of us during our, Dr. B, what's up, at Baylor. He was a pain management physician there. And yeah, we all got a chance to work with him and played a huge part in all of us probably going into pain.
Yep, he was the best teacher on how to read an MRI.
I mean, like he would pimp you so hard. You better know how to read an MRI. But that's why I don't know how to read an MRI to this day. Yes. Thank you. So, I guess it's on me. So the ACGME Sports Fellowship is extraordinarily competitive for PM&R. There's, like I said, there's 18 PM&R only sports medicine programs that take one fellow. And then there's a handful of primary care, that's usually family medicine based, that take PM&R. So there's typically like only 21 spots available for ACGME Sports Medicine. The application process opens in October. And then it's about a 4-week interview window. And then you can start ranking in November, and then you have to have it in by December 4th, I believe. And then usually the first or second week of January is when the match is. And to be competitive for ACGME Sports Medicine program, and like I said, we can talk about it more when I have Rachel on, Dr. Willabelle, next weekend. You want to show a variety of sports medicine coverage. You want to have, and I'm sure the boys can probably talk about this, how much experience did you have with doing injections prior? Like, they want to see that you do have some kind of ultrasound ultrasound experience for sports medicine, because it's such a huge part of sports medicine right now. And just different, sports coverage is huge. But how much experience, boys, were you guys expected to have, or were you asked about when you guys were training or in your interview process?
I would say, experience is key. Dr. B and I got several months together, which was great.
Mm-hmm. We did a lot of pain at Baylor.
A lot of pain.
Nice.
We probably had 2 or 3 months, I think, at least, maybe more. And then Dr. Conan, I also work with there. So we'd got another 2 or 3 months. So, I walked into fellowship with, 6 really good months. I also spent a month at Southwestern. So almost a half a year of training before I'd gotten there, which was nice. Beyond just getting in, it also gives you a leg up on, your other fellows you're going to be, because, I walked into my first, day of fellowship knowing how to do a transforaminal, knowing how to do an interlaminar, which is nice because I'd gotten the experience with those guys, Dr. B and Dr. Conan, and then it allows you to spend more time focusing on other things you're going to add to your skill set, like stimulators or pain pumps. You're not having to worry so much. So, I definitely feel like that was invaluable. And also you can, have better conversations with the people who are interviewing you, because you can talk about things that, cases that you've gone through, and, just show your level of knowledge. So it's definitely valuable. And then also finally, the letters of recommendation, definitely appreciate that. Thankful to both the individuals I mentioned, for the letters they gave me back then, definitely goes a long way.
He paid them a lot of money for those letters, you guys. And Tristan, I'm sure you had a similar experience. Were you guys asked like the specific number? Because the reason I brought that up is one of the Baylor residents was asking me the other day. He was like, one spot was asking me like they expect you to have like 200 injections coming in. Did you, find that you were asked that?
Yeah, I when I started my program, told us at the beginning they didn't expect us to have much experience. So they kind of treated us like, we didn't have any type of interventional experience. So they just kind of started us from day one. We had like a good kind of general orientation period. We had a couple of practice models that we were able to use. and then we were in the process of getting this. So Boston Scientific came out with this nice simulation model. So I think Benecia and Sheena and I practiced on it before for simulators.
Mm-hmm. Yeah. Yeah.
It's a really cool model, just super pricey. So we had obtained that at the beginning of my year, and so we practiced on that a couple of times. But going in, like Justin, Benecia, Sheena, you know, I was fortunate because we had a lot of pain experience, interventional spine experience in residency. So I felt like I had a bit of a leg up, but you know, there are programs that don't expect much from you at the beginning. I also did surgery as my intern year, so I had a bit of a leg up in terms of the bigger procedures like the stim implants and the pain pump implants. So I would say if you want, I would practice before going into fellowship. And if there are any courses that you can take, I remember Furman had a course that he invited residents to. I think it was around like springtime every year. So you get to go up to Pennsylvania and you get to train with him and his staff for about 2 or 3 days. So I thought it was a good workshop just to kind of get you oriented and get some experience under your belt.
Yeah.
And I think you kind of go ahead. I'm sorry.
I was just gonna add, like, I agree with Tristan. I don't think experience is like necessary to get into a fellowship, and that's what you're doing a fellowship for. Is you spend a year doing those procedures. Sometimes it's nice to not have anyone else's, you know, bad habits, or, you know, and just kind of learning from like a clean slate, like learning from, you know, the people that are going to be teaching you for a year. So I don't think it's absolutely necessary. It's helpful to at least know kind of the anatomy and the terminology,
what you're looking at,
a fluoroscopy image, like, and kind of understand that. I think that is something, if your residency doesn't have, you know, as much hands-on experience as maybe that we got, it's not, you know, it shouldn't deter you from applying to these fellowships, you know.
Totally agree.
In terms of the, so for me, for application process for the non-ACGME fellowships, it's a handful to say, my God. So when I applied, there wasn't a match. So, you know, you applied, you have to just kind of do your own research and apply to these particular fellowships, and you go and interview there. When I applied, they were testing out this common offer date where if the place would offer you a spot, they would call you at 9 o'clock or something on this particular Saturday, and you had to decide within 20 minutes or so if you wanted to take that spot. It wasn't the best process. And this year, actually, there are, I think, 22 programs that are now part of, they've kind of made their own kind of accreditation. It's called the Interventional Spine and Musculoskeletal Medicine fellowships. They're accredited through NASS, so North American Spine Society. So they're actually doing their own match. So the fellowship I went to is on there, and I'll put the link at the end of the video of, like, actually, let me have it right here. That has a list of those 22 fellowships, and so they're going to do a match, and so it'll be interesting to see how it goes. I think it's good. It'll be more, you know, everything, you know, all the fellowships will be on the same page in the terms of, you know, what are their expectations in terms of education requirements and all that. So it's giving them a more legit kind of a program. So when people do go out and apply for jobs, they can see, okay, you know, they came from one of these 22 programs, that they know that they will have good training. Because that's the thing with these private practice fellowships, sometimes you don't know, you know, because it's not, there's no accreditation process. So I think it's good, you know, with these 22 fellowship programs, and I think it's good. So we'll see. The match is on August 5th, 2020 this year. So you apply late PGY3 is when we applied.
September-ish or something like that.
Yeah. and then you interview in the summer, and then so they're keeping that same timeline, but the match will be a little bit later in August.
Right. This is kind of a random thing that came to me, is things that we did during residency to kind of get exposure and then make yourself competitive. I know Sheena and I, we try to take every opportunity to take any kind of course or conference that we could. If we weren't able to get in the course or conference, we often volunteered to be models to get that experience and get that hands-on experience. And I think that was very an invaluable aspect. So if you could have an opportunity to do that, I know with COVID, things have kind of changed and people aren't having conferences like they were, but if you are able to volunteer to be a model for anything, definitely do that. I know Region X usually has in Colorado has a conference every year, and they have multiple times a year where they are doing different courses, and they offer for residents, they will pay for you to come out there and actually do it. We got an opportunity to do that twice, and you get hands-on with fluoroscopic intervention and ultrasound intervention. So.
All right, so let's talk about like what our current practice is and how did your fellowship prepare you for your practice? Just if you want to go first, we'll continue the same order.
All right, well, so I kind of have two practices, honestly. I do pain management and I also do addiction. So they both kind of found each other at the same time. So pain I was already interested in from my time in residency. I thought that, private practice was the way I wanted to go in. I was able to work in all sorts of settings in my fellowship. We worked in the government setting, we worked in academic, we worked in private practice. So, I think it's good to have that exposure to figure out which route you want to go into. For me, private practice, I think is, fits my personality, wanting to go hard and, see as many people as possible. And then also, be reimbursed for that. That being said, I appreciate the other areas. Academics in particular is fun. Stuff like this, getting to give back is definitely awesome. So, it just fits, whatever fits your personality, I think is the big thing. For me, in pain, I was always interested in finding things that could treat the patient without making them worse. And, one of the things that I'm, very against is high dose opiate prescribing. And so, while I was there, I was fortunate enough to, meet another guy who introduced me to addiction, which is kind of the opposite side of pain. And I was able to, learn other techniques for treating those patients, and then learning things like pumps and stims, that help to reduce the risk to the patient. Stimulators in particular help reduce the amount of opiates used. There's been good studies on that. And then also pain pumps, which put the control back in your hands. So there's less risk, in that sense. So, I've kind of created two types of practices for those types of patients, to be able to manage the full spectrum of a patient, from those who just need injections to those who are on high doses who might benefit from neuromodulation, to the ones that, fall off the wagon due to, aberrant drug screens that need other additional help. So I've kind of created that. I have these two practices to do that. So it makes life easier, but definitely that's where I'm at now.
Nice.
Tristan, tell us about your practice.
Yeah, I actually am. My practice is a bit different from what I did in training. So I'm in private practice in a multi-specialty group with an orthopedic spine surgeon and another general orthopedic sports medicine surgeon. We do a fair amount of bread and butter interventional spine. Not too much high dose opioid treatment, but I do have a couple of patients that are on opioids. So doing a fellowship in pain, I felt pretty comfortable dealing with those types of patients if needed. I would say my fellowship, when you look at ACGME fellowships, a lot of them don't have as much volume in terms of patients that you see on a daily basis. But I think my fellowship, we had a fair amount, so it transitioned pretty well to private practice. So private practice on a daily basis, I'm seeing around 20 to 30 something patients a day. And during fellowship, I was seeing around 15 to 20 per day on my own. So I think that definitely helped me transition into private practice afterwards, just the daily volume. and also the procedure amount as well. So, with private practices, you can vary anywhere from, I want to say 20 to 20 plus procedures per week. And we were doing that on a weekly basis as well in fellowship. And I also do a combination of neuromodulation with spinal cord stimulator trials, implants, as well as kyphoplasties. So a lot of the procedures that I learned during fellowship, transitions well into private practice.
Very good. You guys want to, I was like, you guys heard about my practice. My practice is very diverse. I do everything. So I consider myself more of a general physiatrist that does some intervention. So I am in the hospital doing consults, usually 3 or 4 times a week. I do outpatient clinic every day. I do ultrasound injections in clinic almost every day. I do fluoroscopic intervention usually 3 to 4 times a month. I just pile them all on one day. And I will go to a long-term acute care hospital and do rounding. And then I also take call at a inpatient rehab hospital where we have an 18-bed facility that me and my partners run. And I take call there every 4th week. Yeah.
There we go.
Literally a little bit of everything. But it's fun. I love it. And what's nice is because my fellowship, it really has helped me transition into my current practice very well because it is a general physiatry practice. And then my partners also get to send me some interventional stuff. So it worked out perfectly.
Nice. Yeah. And so mine, you guys know, we've talked about what our practices look like, but so mine is, I work at Texas Back Institute here in Plano. So it's a group of about 22, 23 physicians, mostly surgeons, orthopedic surgery and neurosurgery, all in spine. And then there's 3 PM&R physicians. So what's nice about my fellowship, what it prepared me for, my current job is because I did a fellowship in a private practice, that transition going from fellowship to, my current job was pretty actually seamless in terms of, I already was seeing the amount of patients that I would be expected to see in private practice, and I already knew everything about billing and coding. I had a lot of that hands-on experience, so I do about 40 injections a week, and I do so my fellowship, we were trained in cervical, thoracic, lumbar, so the whole spine. There's some fellowships that only you get trained only in lumbar,
and that's like how mine was. Yes.
Yeah. So if you know that you want to do cervical injections, make sure you do your research when you are applying to the fellowships.
For sure.
And then also look at the numbers of the different, fellowships, like how many procedures do you actually get experience in? And so that's another important thing to, ask the graduating fellows or the fellows that have, graduated before, and, just ask them what their numbers were, because that will be super important.
And it's huge when you're applying for credentialing because you're going to have to turn your login, case login.
Your procedure logs. Yep, exactly. So
if you want to get credentialed.
Yep.
I think we have some good questions. Yeah. Okay. Royce wants to know, what strengths does one have being a PM&R doctor rather than an anesthesia doctor going into pain management or intervention? Well, we're 4 PM&R doctors, so we like to think we are, but no. Anesthesia is great. Anesthesia pain. I have friends that are anesthesia pain, and they're amazing. Like I said, when we were in residency, we worked with the anesthesiologist that was pain, and he loved having PM&R because we are spending 4 years before going into our fellowship doing hands-on musculoskeletal exam, and we are experts at that by the time we go into fellowship. So I think that is one of the biggest heads up is our exam skills.
Yep. Finding those, those nuances on the physical exam. And I think just also maybe how we approach patients, not taking anything away from our anesthesia pain colleagues, but
yeah, they're great.
We focus a lot about like quality of life and function, right? Those are the 2 main things in PM&R. So I think, bringing that view to how we see our patients is really very helpful, especially in the field that we're in, the subspecialty that we're in, pain management.
Right. And we're all very much pro physical therapy and trying to get our patients better if we don't have to inject them. I tell every single patient that, like, if I can get you better conservatively, that is always my goal first and foremost. And if you need additional help after that, then I'm here to inject you.
I think also the prescribing angle, you know, in PM&R, you see a lot of pain management type patients where you're prescribing them, you know, pain medicines, especially spinal cord injury patients. And, you know, sometimes post-stroke, you see a lot of central, you know, pain, you know, and then the musculoskeletal stuff, obviously. So we've got a lot of experience prescribing opiates, I think, beforehand, but also understanding that, you know, things like a pain score is not necessarily the most important thing. So we see the world more from a, you know, functional aspect. And so a patient may come in and always say, my pain is 8, 9, you know, regardless. And we're able to tease that out and say, you know, well, is that just your number, or are you having a better quality of life and you're doing more things? So your 8 is, you know, was a 4 before, you know, so it's not necessarily correlating directly, you know, sitting and standing are going to cause different pain scores. So that's something I think we do really well, rather than just running with a pain score. I think we're better suited to prescribe responsibly because of, you know, us seeing the patient's going to, you know, need different things for different outcomes.
Yeah, I feel like PM&R, there's very few other specialties that really know how to manage spasticity with like spinal cord injury, traumatic brain injury, stroke. You know, I do see not too many, but a fair amount of patients with spasticity in clinic as well. And of course, we also do EMGs. We have the potential to do EMGs compared to anesthesia.
Which is huge.
Yep.
Which is huge in a spine practice.
Yep.
Right. And so I actually didn't do any EMGs my 1 year of fellowship. And then coming back into it, it was a bit of a learning curve just to kind of get back into it and brushing up on Preston Shapiro and that Easy EMG book. So yeah, I would say I would agree with that if you can do some EMGs and you plan on doing EMGs later on, it's good to keep up with those skills during your fellowship year.
And I would say if you're planning on working like in a multidisciplinary group with the spine surgeon or ortho spine neurosurgery, they're going to expect you to do EMGs.
For sure.
That is a huge part.
It's a great
skill.
Great skill. It's extra revenue, you know, that you
it pays very well.
So the reimbursement still is pretty good. So
yeah, absolutely. Okay, what else do we got? Okay, Carter wants to know, in general, for non-academic jobs like a private practice or group, how often do they prefer to hire candidates from ACGME fellowship or non-accredited? Also, how important is it to be board certified or board eligible in sports medicine or pain when searching for a fellowship, or searching for a job? So to answer in a private practice, I would say they don't care. Would you guys agree with that statement?
Yeah,
I think.
I agree.
Yeah, I think the only time that people are going to care is if you're going to be in academics, maybe, and that's a maybe. I don't think it's necessary. The only time, like for sports medicine, to be board certified is if you plan on being a private, in a professional or a collegiate athlete. I take care of collegiate athletes. They're going to expect you to be board certified. If you want, I took care of PCU during our fellowship. It was a great experience, but I knew it wasn't for me when I finished. But yeah, if you plan on working at a D1 or D3 school, any college really, they're going to expect you to be board certified in sports medicine.
I agree. Yeah, I had no issues finding a job.
Yeah,
being credentialed.
I think that's really the only thing that's yeah. Okay, what else do we got? Yeah, we've got a lot of questions. Okay.
Questions? Okay, here's one earlier. So is it possible to complete multiple ACGME accredited fellowships for those interested in multiple fields of or hybrid careers, example, sports and pain? I don't think it's necessary.
It's not necessary. I mean, I do pain, and I'm probably going to take the boards for addiction here in the fall. You know, part of it is, you know, experience. I think once you get out, you see the types of patients you want. You know, I think that depending on what it is, you may be able to do a practice pathway to get in versus a whole fellowship. And then also it may not be necessary. You know, you may be able to just do enough sports in your practice, like you said, with the credentialing question, you may be able to just do what you want to do, create the practice you want, and not necessarily be board certified in all the areas that you want to practice in.
Right, and we're PM&R physicians, so like coming out of residency, you're going to be able to do sports medicine in the sense that, like, take care of joint pain, shoulder, knees, all that. You're going to know how to do those injections coming out of fellowship.
Residency, coming out of residency.
Out of residency. And so you don't need to worry about going to an ACGME Sports Medicine fellowship if that's all you want to do. If you want to, like Benecia was saying, if you want to do gain more experience in the spine interventions, that's when you should do a fellowship.
Right.
And if you know that you're going to want to do pain pumps and kind of a
kyphoplasty,
kyphoplasty, then go to an ACGME pain fellowship. You'll still learn, general MSK stuff that you've learned already in residency. So you'll be prepared to do that. So, and if you know that maybe you don't want to do as much of the pain in the sense, pain pumps and kyphoplasties, there's plenty of great sports and spine fellowships, that are on that list that I sent out with that link. So, like
Sheena said earlier, it really is going to depend on what you want to do. I think you have to know that decision, and you can base your fellowship choice based on what you want to do when you're done. Carter had another question about finding jobs and not keeping options open. I think Justin kind of clarified that earlier on the talk. He applied pain, can keep options open because there used to be a stigma that you wouldn't be able to get a job doing non-ACGME sports and spine. That is not I know plenty of friends that never had trouble finding a job doing this in non-ACGME sports and spine fellowship and make plenty of money.
Carter, I'm credentialed in 5 hospitals here in DFW. And they don't.
Exactly. And I'm credentialed at a couple. And I did a sports medicine fellowship. Really, it's going to come down to numbers and how many injections you're doing. And they're going to have a person that is either board certified or doing that's going to look at your case log and say, okay, they are proficient in doing this. We're going to give them access to our facility.
Also, the reimbursement's not going to change. So we all know
we all get paid the same amount for the same injection.
The same whether we do, a fellowship or not for the same injection. So that's what really matters at the end of the day.
Yeah, that is a very good point.
Speaking of money, no one has asked this, but I'm sure everyone wants to know, in general, how much money does a, interventional pain management physician make?
Mm-hmm.
It depends on, your volume, right? So, generally speaking, you're going to come out and you're going to be offered a salary, that generally will change into maybe an RVU based model or a eat what you kill based model, depending on the practice. I always caution, young physicians not to come out and look at just the base salary because your compensation may include other things, including, surgery center income or, ability to participate in ancillary revenues such as, lab, DME, et cetera. So, be careful. Also, some practices, I've heard some bad stories about, physician loan or physician draw, where if you don't make the money that they pay you owe that back. And so, be careful, don't sign a long-term deal. Your first job, I think, is probably a good idea. 50% of people will be in a different job within 2 years of graduating, so it's pretty common to move on. Also, I would say that, if you are having doubts about that job, get an idea from the vendors in the market about, what might be the best place for you to land. So places like St. Jude, Medtronic, Boston Scientific, they know all the practices in the area. And so they can kind of give you a map of who's good and who's not good. Especially as a fellow, it's a good time to go to those courses, make those connections. They can give you a handicap on any market in the US and give you an idea of where is a good place to apply and not to apply.
And no numbers were said, so I'll just say the numbers.
Shoot them.
So I think, coming out out of fellowship, it depends on, where you are right in the country, but I'd say on average, having a salary of $225,000 to $300,000, I think is, pretty much what to be expected that first year. Mm-hmm. And then after that,
The sky's the limit.
Yeah, anywhere, 300, 400, 500, even 600, 700,000, sometimes depending on the kind of procedures that you're doing and your patient population. Volume, yeah.
Yeah. Okay. What's up, Justin? Gasper's on.
Oh,
Hi.
Hey.
Hi, Gasper.
loving all the support here. Okay, let's see. Naveen says, I have heard non-accredited programs have contracts specific to their program and fellows after negotiations, for example, with non-compete clauses, etc. How will having a match for non-ACGME accreditations, non-ACGME accredited programs affect contract negotiations? I don't think I fully understand that question.
So I think she's saying if you went if you were at your program and they're like, okay, when you go look for a job, you have a non-compete, you can't find a job within this 5-mile radius of your job. I haven't heard that.
I mean, I think so.
It makes sense.
Yeah. My practice did have something like that, but the non-compete was it was like 2 miles or something like that.
Yeah. Yeah.
So,
I don't think any place that's going to have a non-compete more than 5 miles is ridiculous.
Yeah. Yeah.
And it also varies depending on state too. So I'm in California, and in California, you cannot enforce non-competes, which is a good thing.
I didn't
So
know that.
I would just also look into that as well. Even though there are some contracts that might say it on the contracts, it's actually a law that you cannot enforce it.
All right. I think that's our cue, huh? To wrap it up.
Yeah.
Let's see. Any other last minute questions?
Dr. Gasper dropping some gems in this comment section. He says, don't sign a contract on a draw. They can make the numbers look amazing when all the projections are not concrete.
Yeah. And we'll definitely have another talk on finding a good job, and like what and all of that. So
yeah. And also I want to say we will actually be having Dr. Stephanie Toe on at the end of June, and she is a physician that did 2 fellowships. So to kind of answer the other person's question, she is a rare gem. So to do that, which is amazing. You'll get to hear her story. So but tomorrow we are having Dr. Yi Chu. He is probably one of the best medical students that I had a chance to work with, to the fact that I actually called the program that he wanted to go to talk to the program director and highly recommend him because he was that great. He is finishing out his intern year right now. So he'll be on to tell you like how to rock out your MS4 year and what to expect during your intern year. And we can kind of give him some feedback on what to expect starting your PGY2 year, because that can be definitely a big jump going from your intern year into rehab and starting from scratch again.
Yep. And, as always, you can always follow us on the Virtual Physiatry Mentors on Instagram, Facebook, and YouTube. So I'll have the edited version of the video today of our talk today on YouTube. That'll go up later today. So
yeah, and we'll be turning this into Hayden is helping us turn this into a podcast. So I know a lot of people like to listen while they're driving. So we'll have that link available for you guys soon too.
And just want to thank our guests today, Dr. Thompson and Dr. Zhang. It's good to see you guys.
As always.
Good seeing you guys as well.
And if any of our viewers have any questions, specifically for you guys, how should they contact you?
You can always email me. My email is justin@dallaspainconsultants.com. So feel free to shoot an email, and I'm happy to respond back.
Are you on Instagram, Justin?
I'm also on Instagram. Yes. As JHToms84, and then also Foundation Medical Group of Texas. You can find us as well.
You can reach me at my email, tristan.zhang@spineandorthocenter.com.
Tristan is not on social media, unfortunately. Or if he is, we don't know about it.
He might be keeping it secret from us.
I'm a little behind on the social media. I think my practice just made a Facebook account for me. So once I get a hold of that, I'll send it to Sheena and Benecia.
We'll put it up for you.
Yeah.
Yeah, that'd be great.
All
and
right,
you guys know how to get a hold of us. So, hey, thank you guys. It's always a pleasure. We appreciate you.
Absolutely. Take care, guys.
Thank you.
Bye.
Bye. Bye.
Bye-bye.